que es prevención conjunta del ictus en problemas cardíacos y la demencia. De igual manera, al igual que el anterior, tema, este va a ser un tema pregrabado ya puesto que el doctor ya lo tenía grabado para una de las conferencias justamente del American Academy, y bueno, ahora tendremos el gusto todos nosotros de poder escucharlo. Seremos partícipes justamente de este gran tema. Siendo así, entonces agradecerle también la participación del doctor Vladimir Hashinski. Como todos ya lo hemos podido ver al inicio, el doctor se encuentra también acá en nuestra plataforma virtual para poder responder a todas las preguntas que vayan naciendo para el doctor. Siendo de esa manera, entonces, muchas gracias, doctor Vladimir. Vamos a dar inicio a su conferencia del doctor Vladimir Hashinski.
The Robert Wartenberg Lecture is the premier award sponsored by the American Academy of Neurology for a lifetime achievement by a neurologist for excellence in clinically relevant research. The 2020 Robert Wartenberg Lecture is presented by Dr. Vladimir Hashinski. Dr. Hashinski is Professor of Neurology and Distinguished University Professor at Western University in Ontario, Canada. To all of us in the field of stroke, Dr. Hashinski is simply a giant of vascular neurology who introduced the concepts in terms such as multi-infarct dementia, leukaryosis, vascular cognitive impairment, the brain attack, and also devised the Hashinski ischemic score that remains the standard for identifying a vascular component of cognitive impairment. He has contributed to over 850 scientific papers, book chapters, editorials, and other scholarly publications. Dr. Hashinski is a recipient of the Order of Canada, the Order of Ontario, the Queen Elizabeth II Diamond Jubilee Medal, McLaughlin Medal of the Royal Society of Canada, and is an inductee into the Canadian Medical Hall of Fame. In addition to a great multitude of his neurological research and academic accomplishments, Dr. Hashinski served as editor-in-chief of the journal Stroke, the leading publication in the field, for 10 years. Was vice president of the World Stroke Organization and the president of the World Federation of Neurology. His lecture is entitled The Threatened Brain, Preventing Stroke and Dementia Together. Welcome, Dr. Hashinski.
Hello, I'm Vladimir Hashinski. Dr. Rost, President Stevens, fellow members of the Academy, ladies and gentlemen, I'm immensely grateful for the great honor of delivering the Wartenberg Lecture. I also am grateful to all of those who made it possible, my mentors, my students, my colleagues, and my patients. Once we flatten the COVID curve, three curves will show themselves with stark clarity, and that is the increasing prevalence of heart disease, stroke, and dementia. Although I'll be talking about all three, the emphasis is going to be on dementia. One can summarize the history of dementia in the following way. First, it was all hardening of the arteries. There was a slow strangulation of the brain's blood supply, the neurons died, and that produced senility. Then dementia became almost synonymous with Alzheimer's disease. And now we're at a stage of sophisticated confusion. Let me explain. It's a state of bewildering complexity that follows discoveries but proceeds to understanding. What I have in mind are the many and contradictory definitions of what's called dementia of Alzheimer's disease in the old age. The reality is a bit more complex. It is obvious that in old age, multiple pathologies prevail. And in one study, it was found that the average patient who is diagnosed with Alzheimer's disease has 8 neuropathologies. And even they only explain 67% of the manifestation of dementia. A third remains unknown. So it is, I think, unrealistic at this stage to try to get all the facts we know about dementia and try to put them in a neat category, such as Alzheimer's disease. There is a Canadian rock group called Rush, and they have a song in which they say, you can bend realities, you can bend perceptions, reality won't budge. So rather than talk about Alzheimer's disease, I think we should talk about Alzheimer's syndrome. By this, I mean a syndrome resulting from multiple pathologies, interactive, aggravated by fragility, and tempered by resilience, but on the shifting background of aging. There is a way of cutting through the Gordian knot of complexity, and that is the concept of vascular cognitive impairment. It simply means any cognitive impairment caused by or associated with vascular factors. And the idea is that it covers the whole spectrum from asymptomatic cognitive impairment to all the way to full-blown dementia. And the important thing is to evaluate the cognition, identify the vascular component, and then either treat it, prevent it, or both. Rather than making up criteria, what we decided to do was to agree that whatever studies we were doing, we would collect the same core information in terms of epidemiology, in terms of clinical features, in terms of neuropsychology, in terms of what's required for imaging, for biomarkers, and for pathology. And the idea is that if we use the same data points, we can make provisional definitions and criteria. And then as we learn more, we can refine those criteria so that they will be evolving, continually improving, and also they will be evidence-based and not eminence-based, as is now the custom. People get into a room, they used to get into a room, now they get together by Zoom, and they make up these criteria that by definition contain false information or no information because we don't have all the knowledge. So better to progress stepwise and keep changing the definitions, because if you collect them in specific data points, you're able to use the same data points to construct a better interpretation of whatever study you have done in the past. Now, here's why I think that treating the vascular component is so important. This slide shows you that a quarter of individuals who are cognitively normal will have Alzheimer's pathology. And the really significant point is that if they also have a vascular component, that doubles the chances that they will manifest with cognitive impairment. It is also obvious that all major dementias have a vascular component, from 61% in frontotemporal dementia to 80% in Alzheimer's disease. And the important point here, again, is the same, that the presence of the vascular component doubles the chance of developing dementia. Control the vascular component, and you can diminish, prolong, or mitigate the effects of the neurodegenerative pathology. The one fact that is not truly appreciated is that most people who have a stroke don't know it because they have no symptoms. If you examine these patients, they have some cognitive impairment, but they're unaware of it. And the other thing that we haven't quite appreciated is that despite the fact that we've known for quite a bit of time that for each clinical stroke, there are 4 so-called silent or covert stroke, that these are very common. Already in the 40s, 3% of the population has one or more of these. And by the time they reach their 70s, 19% have it. And the more silent infarcts they have, the greater the decrease in cognitive performance. The most powerful element that leads to dementia is stroke. And by now it's incontestable that having a stroke doubles the chances of having dementia. Now, we know that in principle, we could prevent 90% of strokes. So the more strokes we prevent not only strokes, but some dementias. There are other encouraging developments. You must be aware by now of the famous finger study in which they showed that an intensive lifestyle intervention actually preserved cognition. Another encouraging development is that atrial fibrillation is associated with dementia, even beyond multiple infarcts. And in Sweden, they showed that if people with atrial fibrillation were anticoagulated, the risk of developing dementia was cut by 48%. The other famous study that's come out recently is the SPRINT study. And as you know, they studied over 9,000 subjects at risk of vascular disease, and they randomized them to a target of 140 or a target of 120. After 3¼ years, they had to stop the study because all the outcomes seemed to be in favor of the lower target of 120 millimeters. The other encouraging thing was that it looked as if mild cognitive impairment was decreased by 19%. Now, I am an enthusiastic supporter of treating hypertension, but I'm not in favor of treating hypertension enthusiastically. On the contrary, I think I should do it slowly, cautiously, and individually. And let me explain why. We used to think that autoregulation, in other words, the capacity of the brain to keep the blood supply constant, was rather broad, a platform of about 50 millimeters of mercury. So in other words, doesn't matter if you're still in your head or jump up and down, the blood pressure to the brain would be the same. However, we have found out that that platform of constancy when the brain can autoregulate is much narrower. It's closer to about 10 millimeters. So clearly, if you have a hypertensive and you treat the blood pressure too quickly, you may get side effects clinically, or you may damage the brain. And I'm going to show you why a blood pressure measured either in the arm or centrally is not a good guide to the circulation in the brain or the pressures in the brain, because as I'll try to show you, I believe that the brain has two complementary systems, a high pressure system and a low pressure system that need to be in fine equilibrium. What I'm showing you here are the brains of a dogfish, a frog, a turtle, and a chicken. And what they have in common is that they are tubed with an enlarged end, which is the brain, and they're supplied by a basal artery that has branches coming out at right angles. Now, this pattern is preserved in the human. This is a brainstem. As you can see, there is an enlargement, there is a basal artery, and there are branches coming at right angles. This pattern is not limited to the brainstem. It is also present in the basal ganglia and the thalamus. This coronal section is going to illustrate the point I'm trying to make. And that is that if you look at this coronal section, the part of the basal ganglia at the center of the brain is what I'm calling the primitive brain. And if you concentrate on the circle of Willis, you'll appreciate that the arterial blood pressure that is present in the circle of Willis has to be stepped down to capillary pressure over a relatively short segment. That means that in order to autoregulate, those little arteries have to really work hard to compress the lumen so that the brain is not hyperperfused. The consequence is that with hypertension, these walls are enlarged. Sometimes they develop hyalinosis, and ultimately they may close off, producing a lacunar, or they rupture, producing a hemorrhage. Now, again, I want you to concentrate on the circle of Willis, and then imagine the arteries going around the brain, and then giving branches that go in to supply the white matter. Now, I'm calling the rest of the brain the Homo sapiens brain, in other words, the human brain. And what happens is that because you're stepping down the arterial pressure, the capillary pressure, over a long segment, there isn't that much pressure on any given centimeter of the arteries. And by the time that the branches penetrate in the brain, it becomes a low pressure system. And there's some evidence for this. It has been estimated that when the blood pressure in the arm is 115, then in the primitive brain, which I have colored in red, in blue, the blood pressure is 113/73. And if you look at what I'm calling the Homo sapiens brain, it is 56/38. It's not too hard to imagine that a sudden drop in blood pressure could produce some deep damage in the brain. And the other thing we don't know about is that normally the blood pressure drops at night, and so heaven knows what happens to these two systems in sleep. There is a bit of clinical evidence for this concept, and this is a case of a 60-year-old man who had CADASIL. And he was in a car accident, he went into coma. And initially, he had the typical periventricular white matter changes you expect in CADASIL. After 6 weeks in a coma with a blood pressure of 60/40, he developed the typical coin lesions deep in the hemispheres of the Homo sapiens brain to suggest that indeed the greatest damage was done because of the hypotension. So now you understand why I'm advocating that we should be very careful in controlling blood pressure, and that one of the greatest needs in personalized medicine is to know what's best for my brain. By the way, the term ambibaric brain you never heard of, because I invented it with the help of Professor Paul Potter, who is an internationally known scholar and translator of Hippocrates, and he's an expert in ancient classical medicine, both Greek and Roman. So the word we came up with was ambibaric, and so the first component is ambi, which is Latin for both or two, and then baric, baros in ancient Greek, which means pressure, and we use it in the word barometric pressure. This concept of the ambibaric brain might also explain why is it that hypertension tends to affect executive function. Now, executive function is largely subserved by the frontal systems. And the frontal systems have the same pattern. For example, you go from the prefrontal cortex, you go to the basal ganglia. From there are pathways to the thalamus, and then there are pathways back to the part of the brain where it came from, in this case, the prefrontal cortex. The same pattern applies to the frontal medial system and also to the anterior cingulate system. So as you can see from the diagram I'm showing you, on the left, you can see a diagram of the different systems, the circuits. But on the right, you can see that this is right in the territory on the primitive brain where the vessels get damaged first. So if you damage the vessels, you damage the white matter. And that explains why you have white matter lesions around the head, around the ventricles, and also why you have executive function. And in fact, last month, there was a paper published that showed that even in asymptomatic individuals with high systolic blood pressure, there was a worsening of executive function. So clearly, this is a potential explanation on why executive function is important to measure in all individuals with high blood pressure, because they're prone to develop both a stroke and dementia. One type of patient who is very prone not only to develop stroke, but also to develop dementia are people with a TIA or a non-disabling stroke. And we did a study in which we showed that 5% of our patients had memory impairment, but this was no different than people of similar age and the same sex. On the other hand, if you look on the trail test B, you can see that 39% of these individuals had executive dysfunction. So I do think that it's important to determine cognition, at least in hypertensive individuals. But it's important that the measure of cognition should be divided, at least in the first instance, into executive function and memory function. Now, I realize that some people present with both to begin with, or if cognitive impairment progresses, doesn't matter whether it starts with memory impairment or executive function, eventually everybody develops everything if they live long enough and the dementing process goes on for long enough. So the reason I caution against bundling cognition is that some years ago, one of my fellows, Shahram Obezgaran, who is now an assistant professor at Rush University, and I decided to ask the question, is there any relationship between high blood pressure and progression to dementia? The answer from the Canadian Study for Health and Aging, which involved more than 10,000 subjects, was a resounding no, which was very surprising to us. They said, well, if hypertension damages the brain, how come it doesn't contribute to progression? But then it occurred to us to divide the sample into those presenting with memory disorder and those presented with executive dysfunction. So the ones with the memory disorder progressed regardless of whether hypertensive or not, the same rate. Then when we looked at the ones presenting with executive dysfunction, we found that 58% of hypertensive progressed to dementia in 5 years, but only 28% of those who were non-retensives. In principle, we could have prevented half of the progressions. One way of identifying the vascular component is by using an ischemic score. And this ischemic score entails doing a neurologic examination. Since it was first published, we have managed to reduce the 13 items to 5 questions that do not require a neurologic examination. We already knew that according to meta-analysis of clinical pathological examinations, that the ischemic score had a sensitivity of 89% and a specificity of 89% in recognizing the vascular component. So then we thought, if it could recognize a vascular component, does it also predict progression to dementia? So we decided to compare it to APOE4. As you know, this is the single most powerful risk gene for developing Alzheimer's pathology associated dementia. And what we found is that the characteristics of prediction were very similar between the ischemic score and the ApoE4 presence. In fact, the receiving operating curves are almost identical. So the big difference is that we cannot change our genes, but most of the items of the ischemic score can be changed. And this gives us ground for optimism. Moreover, we showed that the higher the score, the more likely they were to progress to dementia. So we have an instrument that gives us some idea in predicting who's going to progress, and also the factors that might contribute to it, many of them controllable. The practical advice how to do this is in a book that was highly commended by the British Medical Association. So far, I've talked about managing individual patients, and this is called the high-risk strategy. The reality is that we need to complement this by also having a population approach. And one of the important things to realize, and very difficult to convey, is that it is in the people at low or moderate risk that produce most of the outcomes. For example, stroke. We know that hypertension is the single most powerful predictor of stroke. Now, if you look at the curve, you can see that the highest risk group, the ones with a systolic of 160 or more, represent roughly 10 to 15%, which is fairly typical of risks. It's also true for high cholesterol. So the statement that I'm making is that most strokes come not from the highest risk group, but from the mild to moderate risk group. So that's counterintuitive. Well, I'll give you a simplified example. Let us assume that the people with the highest blood pressure have a 50% chance of developing dementia. And let us assume that the people with mild and moderate high blood pressure only have a 10% chance. However, the high risk group is only 10%, so they'll produce 5% of the strokes. The moderate and mild risk group are larger, 100. And so their risk is 10%, so they'll produce 10 of them. So it is true that most outcomes come from the mild and moderate risk and not the highest risk. That means that we should treat all risk vigorously at all stages, lest people get reassured that because they have a low risk, they're not prone to develop the catastrophic result, such as stroke or dementia. The other point to be made is that small changes at the population level have a big impact. And this is from the atherosclerosis risk in communities study. As you know, it's fairly representative of the population of the United States, and 27% of the participants were African Americans. What it shows you is that a change of 2 millimeters of mercury, of course, is significant even at the individual level, but it's hardly meaningful. On the other hand, if you manage to reduce the mean blood pressure of the population by 2 millimeters, you will reduce the risk of having a stroke by 24%. So we need to use both strategies, the high-risk strategy that we deal in our offices with, and also the strategy that we need to encourage and participate in at the population level. Now, we know that a stroke doubles the chances of developing dementia. And in the province of Ontario, where I live, with a population of 14 million, we persuaded the provincial government to introduce a stroke strategy. Now, that was introduced in several steps and had several components. First, building more stroke units and rehabilitation units, building more stroke prevention clinics, and also undergoing campaigns in preventing risk factors. So we knew from published work from our colleagues in Toronto, Mark and Pardo in particular, that outcomes were improving. So we said, well, the outcomes of stroke are improving. What's happening to dementia? We decided to take a look at that. And what we found was that over a 12-year period, the incidence of stroke in Ontario decreased by 72%, that of dementia by 7%. So some dementias are dropping. Why? If you multiply 7% on a population of 14 million, that's thousands of people. So we're very interested in finding out why is it that both the incidence of stroke and dementia are decreasing. Now, based on our evidence and some other evidence, the World Stroke Organization updated its recommendations, and they expanded the proclamation to include potentially preventable dementias. And this has been endorsed by all major organizations dealing with the brain, the World Federation of Neurology, the World Heart Federation, and then in the United States, it's the Alzheimer's Association, the American Heart and Stroke Association, and the American Academy of Neurology. Now, subsequent to that, a document has been produced that they give the scientific basis why we should be looking at stroke and dementia together, because there are many shared mechanisms at the basic level, at the epidemiological level, at the clinical level. So the outline of the evidence is summarized in this document. And I do think that the time has come for us to unite forces and begin preventing both together, because we have enough evidence to begin making a difference beginning now. Now, I also want to include heart disease, because after all, the core of this is the common risk factors and protective factors. And if you look closely, both the risk factors and the protective factors for stroke, dementia, and heart disease are the same. Of course, there are also differences. And also, dementia, stroke, and heart disease represent risks for each other. If you have a stroke, it doubles the chance of developing dementia. If you have heart disease and have atrial fibrillation, it increases the chance of developing dementia. If you have a stroke, it can produce atrial fibrillation. If you have atrial fibrillation, it can give you a stroke. So clearly, they're interrelated. And I think we'd be much better off if we were to unite our forces together. And then there's a long way we can go together before we go back into our specialized corners. And again, I don't need to remind this audience about what the risk factors are and what are the protective factors. And I think one also should have in mind that the risk factors add up. Not only are they adding up, they multiply. In other words, in a study, having two risk factors more than the sum of the two. You add a third one, it's more than just having the sum of the three. So what an open question is, if you start controlling more than one, are you reducing the risk in the same proportion? In other words, reducing several in small degrees, the same effect as reducing one. It's a good question that I don't believe has similar to the.
Por favor, doctora Sandy Galeano, si puede apagar su micrófono, por favor, está interrumpiendo con la conferencia. Por favor, recomendarles nuevamente a todos los asistentes si podemos apagar los micrófonos. Marta Sandy Galeano está con el micrófono encendido, por favor, si puede apagarlo.
Factors. We have the usual ones of exercise, education, and so on. And there's also another thing that we are just beginning to understand, that there's some individuals who have a lot of the risk factors, and yes, they're fine. You know, a concept that has been broadly defined as resilience. We have a lot to learn from that. As physicians, we concentrate on the risk part, but there are also protective factors. And they're probably not limited to the brain. There are probably all sorts of other factors that are important in this. And that brings us to the question that we cannot hope to stop Alzheimer's processes, stroke, heart disease by focusing on the clinic alone. In terms of risk factors and protective factors, there is a whole conglomerate of these. Who you are, what your gender is, what you do, with whom you live, what you earn, they all are important in determining your health, and more specifically, your brain health. To the best of my knowledge, no one has ever attempted to look at all of them simultaneously to see what degree each of them plays a role. And as you probably know, this is a complex system. And it is the nature of complex systems that as they become more complex, they're emerging qualities. One example is water. You cannot understand wetness by studying water molecules to death. You have to study an aggregate of them to realize what wetness is. Similarly, we cannot understand brain health and how to maintain it without looking at all the elements. Now, luckily, in Canada, it would be possible to do such a study. And we have a uniform healthcare system. We have good data at the epidemiological level. We have data on the environment. There is a census. And so it is possible to do. The big challenge that we're having is to get funding. we get partial funding. Most agencies are very specialized. They're interested in an organ or a disease. So to get health economists, to get health geographers, to get computer scientists under one umbrella, I think it requires a special effort. And of course, that's what we're doing now. We're trying to get the funding to do the things that need to be done so that we can succeed in flattening the curve of heart disease, stroke, and dementia. If we're to succeed, we cannot simply produce an aggregate result, and say, here's comprehensive, here are all the relevant factors, we're going to treat them all. No, we can't do that. And the reason is that the risk varies by community and by individual. For example, even in Canada, where we have a uniform access to healthcare, our communities are not the same. There are communities where have little access to healthcare, some of our northern communities, for example, where there's rampant high blood pressure. And there are communities where there's good control of blood pressure and they have access to care, but there's obesity and prediabetes. So if we're going to succeed, we'll have to, first of all, take inventory of all the relevant factors, but then produce packages at the community level that are most relevant to that community. So it has to be targeted, the most promising combination for a given population or individual. And then you cannot simply go to a policymaker and say, look, this is a good cause, give us some money because, there'll be good outcome. You have to do the exercise of what I'm calling investment value. In other words, if you do X, you'll get this result. If you do Y, you get this result. If you do Z, you get this result. And if you get all three, this is what it'll cost you. This is what you can expect. But the same goes for the individual. Even though risk factors love company, it's good to target one. For example, high blood pressure. And then again, you have to evaluate the investment of time and effort by the patient to see what are they capable of doing. So the most important thing for them is to low blood pressure. Well, let's focus on that. But the main problem is the gaining weight and then a pre-diabetic state, and there's a family history of that. Well, you target that. So again, the important point is that you have to be comprehensive but targeted, and then it has to be investment value in order to make it work. You can read faster than I can speak. So I'm going to give you a minute to read what we're proposing to do. In conclusion, we can prevent most strokes and heart disease and some dementia now by developing strategies for the joint prevention of stroke, dementia, heart disease, and the promotion of brain health, and by adopting a comprehensive, targeted, invested value approach. And if we're going to flatten the curve or the triple threat that I talked about at the beginning, then we have not only to intensify our efforts, we have to diversify our efforts. And we need to do it because there are millions of brains that depend on it. Thank you.
Muchas gracias por la participación del doctor Vladimir Hashinski. Nuevamente recomendarles que cualquier pregunta la vamos a ir realizando, la vamos a ir anotando en lo que es nuestro chat para posteriormente hacerles a nuestros profesionales y ellos puedan ir respondiendo a cada una de las inquietudes o de las preguntas que vayan naciendo, ¿no? Nuevamente recalcarles por favor a todos los asistentes que tengamos cuidado con lo que son los micrófonos para poder evitar y poder escuchar con total claridad a lo que son nuestros expositores. Bien, continuando, vamos a ir con nuestra tercera charla de la noche, que va a estar a cargo del doctor Andrés Salazar, quien es médico neurólogo e investigador, con su tema que él nos va a manifestar o nos va a presentar en esta noche, que es inmunoterapia de tumores del sistema nervioso central. Doctor Andrés Salazar, un gusto nuevamente poder compartir un webinar con usted. Este es el segundo webinar que tengo el gusto. Doctor Andrés, por favor, si puede habilitar su micrófono y comenzar a compartir la
pantalla. ¿Qué tal? ¿Lo pueden ver?
Sí, doctor, se ve. Ya
No.
está compartiendo.
Ok, bueno, voy para adelante. Déjame agrandarlo y seguiré. Bueno, muchísimas gracias a todos y muchísimas gracias especialmente a la Sociedad Panamericana de Neuroepidemiología y a la doctora Beatriz González, quien es una gran amiga de muchos años. Lo que quisiera hacer hoy, y muchas gracias también a todos ustedes que están compartiendo con nosotros y a los laboratorios VAGO. Lo que quisiera discutir con ustedes hoy es la inmunoterapia de tumores cerebrales. Pero este es un tema demasiado grande, cosa que voy a hablar más bien del trabajo que hemos estado haciendo nosotros con una droga